Hi, welcome to the second season of Guts and Glory, wherein we pick the expert's brain on contentious and complex issues and understand these complexities of HPB and GI surgery diseases. My guest today is none other than Sanjay Govil. Sanjay and I have known each other for a long period of time. Uh, he is the ex-professor of HPB surgery from the prestigious CMC Vellore. And for the past decade and more, he's been practicing HPB surgery and liver transplant in Bangalore. His main areas of interest are Hilar Cholangiocarcinoma, complex liver resections, and vascular resections in pancreatic cancers. Sanjay is a multifaceted personality, which of late I've come to know. It seems he sings, acts, paints, writes, reads, and works with his hands in carpentry, modeling. Oh my God, Sanjay, this is like a huge thing. Do we get to hear you sing today?
No, Sadik, I don't think you'd enjoy that very much. I do this all for mostly for my own pleasure to keep me occupied. I used to sing on stage in Vellore, but
There
my
you go.
my voice has gone for a total sixer. I've got now that I'm approaching retirement, I'm trying to revive some of these hobbies which I used to actively participate in earlier.
So great.
Yeah,
Eh, You know, uh, we'll dive right into the your
yeah,
area of expertise in HPB surgery.
sure.
And I like to call this the tryst with the hilum.
Wonderful.
So the hilar cholangiocarcinoma, as you know, is a terrible disease in terms of treatment. I want to ask you something. When we were growing up, pancreatic duodenectomy was the big thing.
Yeah.
And we used to call that the Cadillac of all surgeries. Now we have this hilar cholangiocarcinoma. It is a difficult disease to treat. It is challenging. What would you call this? Is it a Ferrari of all surgeries now? In
Yeah,
your book?
I think you're right. You probably should call it the McLaren because they're the ones on top at the
True, true,
moment.
true, true. I agree. Yeah,
But yeah, I think, we have over the years gotten very familiar with pancreatic duodenectomy and it's being done quite routinely. But hylacolangio is the challenge lies in the fact that one is the disease is in the location of the disease in the hilum, so close to all the vascular structures. And it's not always easy to reliably determine whether any of these vascular structures are involved in the planning stage.
right.
Sometimes it's an operative surprise, and also you're having to resect quite large amounts of functioning liver in these patients in order to try and get a clear margin,
Right.
and that raises the risk of post-operative liver failure, which is absolutely a dreadful condition with a high mortality. And at the end of all this, your pathologist will not uncommonly report that the margins are involved, and
Yeah.
so the whole thing has been. So it is a huge challenge, and I think it's a disease in which the treatment is still evolving quite, significantly.
Yeah. And we can't forget the patient. I mean, these patients have
Absolutely,
jaundice, comorbidities,
yeah. I
and
mean,
that adds to
absolutely.
the complexity.
That adds, but though, the comorbidities are often the same with many diseases that we see because most of them occur in these age groups.
Yeah.
But certainly the jaundice, the effect of the jaundice, and how that's affected the liver remnant or the liver itself.
Yeah.
Uh, and the age of the patient, how it influences regeneration post-operatively.
Yeah.
I mean, all these.
Yeah, we'll discuss this.
Yeah.
So, if I say that this is one surgery, where I feel that you do a majority of it off the table. You know,
Absolutely.
so the planning part is very critical in this. What do you say? And what
I,
do you think are the elements of this planning? Say you see a patient with
right.
suspected hilar cholangio. I
Yeah.
mean, quickly, one, two, three. What do you think are the key elements in planning of this patient's treatment plan?
Okay. I mean, obviously, you want to know the treatment plan depends on the cross-sectional imaging, I mean, the degree of jaundice, the cross-sectional imaging, and the general health of the performance status of the patient. These would probably be the most important factors. And in the cross-sectional imaging, we would be looking specifically for atrophy, obviously metastasis, atrophy, because that predetermines which side you have to resect. Uh, the extent of tumor involvement into the biliary tract and the vascular involvement.
Yeah,
Uh, then you have to plan your operation. And once you've done that, you've got a certain remnant volume, which may or may not be adequate for the patient. And you have to see whether that remnant can be function and volume can be more important than volume is function can be optimized so that the patient will tolerate this kind of surgery.
I want to understand because there's been always discussion that is what kind of cross-sectional imaging is good enough or adequate, and do you need multiple uh, sets of imaging to get the whole picture? What do you suggest or do you do in your practice? In
I have tended to use cross sectional CT, and on occasion, when I have needed to get a better picture of the biliary anatomy, if I'm unsure, then I would get MRCP in addition to the CT scan. But so if you have the right software, the right machine, the right radiologist, I think triphasic contrast enhanced MR with obviously the MRCP as part of it is the ideal.
I guess MR would add to also the imaging of the biliary system, which would you
That's right. So that's why I think
yeah.
that's the ideal thing because in one thing you've got the all the information that you need.
Yeah,
And you don't really need to rely on things like we used to in the old days, having to do a PTC and do a cholangiogram,
direct cholangiogram.
direct cholangiography, and all that are not no longer
That
necessary.
would you do a PET CT in these patients and FAPI PET, which has come now? Do you think is there a role?
I mean, I must say, I have not used it. Many patients have come having had a PET CT. I'm quite okay with the PET CT, especially nowadays because we get the triphasic. We get a good
Yeah,
quality CT scan with the PET. In some patients, if you're not clear about your biliary anatomy on the CT, that to have to do an MR to get a
yeah.
colangiogram.
A lot of people are hesitant to in current practice and the patients that we see to undergo a major resectional surgery without
Without
having the histological diagnosis. So, how far do you go to get this, and how do you
Yeah,
convince your patients to
right.
take
So,
this major surgery?
yeah. So I don't, I'm afraid, to go very aggressively to get pre-op histology, uh, because pre-op histology generally requires intervention into the biliary system. So my decision on whether or not to attempt a histology is based on my decision on whether or not I'm going to intervene I'm going to do any interventional
Really
procedure
drainage.
on the biliary system.
Yeah,
And the other thing is that the traditional things of histology, like cytology and even the fish and so on, uh, uh,
limitation.
they're very limited, yield from those
Really.
things.
Yes.
And nowadays, of course, you have spyglass and there's all this confocal laser endomicroscopy, which I don't know whether it's available.
Clinical practice, how often do we use that?
That's exactly it. So you have those options. I do tell my patients that with this kind of obstruction in the hilum. Statistically, it's about 95% that this is
Yes.
malignant.
True.
And even if it's not malignant, it requires a resection in order to be able to relieve it. In all these years, I have seen one patient with an IgG4 cholangiopathy, which was mistaken for a Hilar cholangio.
Yeah.
But even that can usually be diagnosed
Yeah.
preoperatively
Now.
nowadays.
Yeah.
So.
Would you attempt a lymph node biopsy, EUS guided, if there is a significant node there? I mean, that may be a better thing to target than the main lesion.
So if there is a node which is going to preclude resection,
Yeah.
then I might do that. I
Yeah.
think, or if it's a patient who absolutely insists
Yes.
that they want to have a biopsy beforehand, then those are situations where I might do a PET also. But then you have to
Yeah.
warn the patient that with a PET, only two-thirds of these
Yeah.
tumors will show uptake. And if stenting has already been performed before they've come to you, then the PET is of no use for a diagnosis unless there's extensive nodal uptake or something like that, or a metastasis.
And Sanjay, the other side of it is one negative
Doesn't mean
doesn't
anything.
mean that, and it's
Absolutely.
a real challenge then to have a discussion with the patient. I guess it's fair to say that if you are intervening the biliary system for some reason, you
Yeah.
would attempt
Attempt.
getting a you know cytology or
Cytology.
histology as you would, and if it comes positive, it's great. If not, you still have to
Absolutely.
talk to them. That's an important thing, which often uh, it's a demand of the patient and we don't know how far to go, but it's good to understand that there are limitations and you need to undertake this without that histology. How do you plan your surgery
Okay.
in terms of how much liver to remove, which side to remove, the subsequent things which you're telling about, that whether the future liver remnant is adequate or not?
So, like I said, the first thing is look for the side with atrophy because that obviously predetermines your resection. The next thing that I look at is actually the vascular involvement because that would complicate it. And we all know that it's the left-sided resections which have difficult vascular reconstructions because the right hepatic artery is the one which is
Yeah.
most is it has a possibility of it being involved if it because it runs just behind the hilum. It's also important to remember that replaced right hepatic arteries or replaced arteries may actually be spared from the tumor because they're a little bit on the side and you
Yeah.
may not little less likely to
Yeah.
be involved if it's a standard anatomy. The portal vein involvement is often not a problem. It's usually on the top, on the saddle of the portal vein, the top saddle. And as long as the tumor has not gone beyond the second order by the portal bifurcation, it's easily reconstructible at surgery.
Yeah.
It's not usually a problem. And then you look at the bile ducts. What you need to know is only up to the second order duct involvements.
Yeah.
So on the right side, I want to know if the right anterior and posterior bifurcation, whether that confluence, whether that is involved by tumor or not. Generally, if it's gone beyond, I would be cautious about preserving that side. And then on the left side, you're looking for the segment 4, and then you're looking to see whether it's gone into the umbilical fissure, because then that makes it likely that you may not be able to resect. You need to resect the caudate because the caudate ducts are always involved.
I think that's an important thing, isn't it?
That's
In
an
Hilar
important.
Cholangiocarcinoma, that
That's
caudate
right.
has
But
to come out,
that's right.
irrespective of what liver you remove. So it's fair to say that most of the time you would be doing right-sided resections to
Yes, that has been the traditional view,
the way.
but there is an increasing view that over the last decade or so that one should consider the increase the consideration of left-sided resections for a number of reasons.
Yes.
One is that if you do a left trisectionectomy, you can get an extra approximately 9 millimeters of bile length in the right posterior duct if you've got traditional biliary anatomy, the normal, which is there in 90%
Yeah.
of people.
Yeah.
And so you're able to get a better margin. Secondly, in many patients, though not all, the right posterior
Larger
sector
volume.
is of a
Yeah.
larger volume than the left
Yes.
lateral sector.
Yes.
And the third most important thing is that your resection volume, especially if you're not having to do an extended, if you're just doing a left hepatectomy, your liver remnant is much
Yeah.
larger and therefore you're much
Left,
safer.
of course, it is.
Yeah, it's
Yeah.
it's it's much
Yeah.
safer. The downside only is the fact that you've got the artery, which has a higher likelihood of involvement, and you then have to make a decision whether you are that if the artery is involved,
Deep
are you willing
resection.
to resect it, or if you're not, then you go on to the having you have to decide that then your only option is a right trisectionectomy in that
Yeah.
scenario.
It just tells us that how complex this decision making is. You mentioned about variant anatomy, and sometimes if you have the right posterior draining into the left duct and it is atrophic and you don't pick up,
You need to think of all these variations when you're looking at the anatomy.
and certainly left trisectionectomy is a more difficult
Tough,
operation than
tougher
right
operation.
trisectionectomy.
Undoubtedly, it's a much
So
tougher
yeah,
operation.
so interesting to understand the changing landscape,
Yeah,
because more expertise is developing in this and people are able to undertake these resections much more
yeah.
confidently. How to optimize the future liver remnant, how you go about making sure that the PHLF or post hepatectomy liver failure is risk is minimized.
Once you've designed your operation, you know what your remnant is going to be like. And as far as I'm concerned, if the remnant is more than 50% of the liver, I don't bother with optimizing. I'm
Yeah,
quite happy to
yeah,
proceed with
yeah,
resection.
that's fine.
Unless the patient has cholangitis or there's
Yeah, of course.
something or some comorbidity which is going to delay the surgery or something like that. If the remnant is less than 40, I'm going to need to do a volume enhancement. That volume enhancement usually will be a portal vein embolization. Uh, and nowadays, although I don't have experience, I know there are many centers which are doing the total venous deprivation. So
Yeah,
combining it with the venous occlusion, hepatic vein
yeah,
occlusion.
yeah,
And these procedures require preoperative biliary drainage.
yeah,
And if it's between 40 and 50%, I would look at the level of the bilirubin. And if I've got a bilirubin up to about 10, 12 in that range, especially if it's a younger person who's otherwise quite fit, I may not do a biliary drainage. But otherwise, if I'm in doubt, if it's anybody who's over 60, 65, for sure I would put in a biliary drain.
it's very critical that your center, I mean, wherever people are doing it, should have a good interventional radiologist.
Absolutely.
Because without that, that's a critical cog in the wheel of
Absolutely.
management of liver optimization for drainage and all so on and so forth. And sometimes you need multiple drainages in an event that there is cholangitis.
Gaiters.
Now, Sanjay, I've had situations where you do a drainage,
Hmm.
bilirubin is not coming down. So on. You've had any situations like this? And
I've had situations where it's not come back down to normal, where it sort of sticks around five or six, five, six,
it's
seven.
at 15, 16, it's just not coming down. I've had two, three patients like
Yeah,
this.
occasionally it has, but it's more common that it comes down, but just doesn't come down fully. And those patients you have to be really careful of because, and I'm saying what I mean is it doesn't come down, then you drain the other side in the hope of bringing the bilirubin down, and then it sort of gets stuck at five, six, seven in that range and
Yeah,
doesn't come down to two, three, around two. It never reaches, goes
yeah,
below five.
yeah.
Those are I've had terrible times with those patients, thinking that oh, it's we've done everything and now the patient's ready. It usually means there's some problem in the liver. Those patients don't attempt to resect them without getting. I mean, the only thing you can do is that if you try and get more volume if you're able to. If there's anything you can do to get more volume, like if you haven't done a hepatic vein
Yeah.
thing, or
Occlusion.
just
Yeah.
wait. Don't be
Yeah.
in a hurry to operate on these patients. They go off badly in the post-op period. If you've drained, you better make sure that the bilirubin has come down to normal.
Yeah, I think that's a key message because if you get stuck in such situations,
Yeah,
it's going to be a nightmare trying
it's
to
a disaster.
deal with
Yeah.
them. The buzzword these days is about optimization, rehabilitation.
Yeah.
So, anything you practice, do you have a plan? Do you have a protocol in your practice?
I won't say that it's something that is very formal. Make sure they get a good diet. Don't be in a big hurry to operate, because this also has been shown by the Amsterdam group that these tumors are usually quite slow growing, and they
Yeah.
tolerate without adverse survival, even prolonged periods of waiting for surgery. So nutrition, exercise. But I have to say that I would say at least about, I mean, you stop me if you think if you had a different experience, but in my experience, at least half or more of these patients, despite their jaundice, one of the features of Hilar cholangio seems to be that they're relatively well preserved
So,
patients. They have not, unless they've been intervened with and then they've got cholangitis and all the rest of it. But if they come to you without any intervention, most of the time they have got good serum albumin. They're quite active and normal. The only complaint is that I'm deeply yellow.
yeah. The point which you made, I think it's very important that there is no rush to do these patients, both because of the disease course and the fact that you're dealing with so many complexities, that
Yeah.
giving enough time and making sure that it's the right time to do
Yeah.
it. And you have to strike a balance,
Absolutely.
how long to wait
Yeah.
vis-a-vis how soon to do that. We get to the surgery. The thing which pours water on all this is that there is a very high rate of R1 resections or microscopic R1 resections in
Yeah.
hilar cholangiocarcinoma. What I want to hear from you is that A, how do you ensure? I mean, it's always kosher to say that you need to achieve a R0
I
resection.
know. Yeah.
60% or so in most series have an R1 resection, or
If you
yeah,
knew that you could not beforehand get a
yeah,
margin, you
you
probably would not proceed
could
with it.
not, yeah,
And that is why I think this idea of the biopsies taking, instead of, cholangioscopic biopsies at the limits of the resection on the right and the left.
yeah,
To me, it sounds like a good idea if you can do it,
yeah,
because it does give you a little more. Of course, it doesn't tell you about submucous infiltration, which is unfortunately
yeah.
one of the features of this disease, but it does give you an idea as to whether you're going to be able to achieve that margin.
So, I mean, it reminds of this Japanese philosophy, multiple catheters,
Exactly.
cholangioscopy, and then do those complex intrahepatic resections with
I
a,
know. Just take one biopsy on the right and one biopsy on the left at the limit of your resection. But otherwise, you go in good faith to do a resection and attempt an R0 resection. Getting 1 centimeter margin on that bile duct is
yeah,
extremely
a
difficult.
challenge.
It's a big challenge. So we're usually somewhere around 5 millimeters, or 4 or 5 millimeters off from the where the tumor is. Literature actually ranges from between 15 and 60%
Yes, yes,
in a positive margin. And I mean, when we looked at our series some years ago, I think it was around in the early 20%. But it's still a significant number of patients with positive ductal
yeah.
margins.
It's
The
interesting that you mentioned that because I was just going through some publications and about the standardization of reporting of pathology.
Exactly, exactly. That's what I was coming to. The
Yeah,
same way in which
pancreatic, yeah,
pancreas
lead
has been
protocol.
done.
Yeah,
There are publications on how the hyla should be managed, and we focus so much on the bile duct margins, but we miss the circumferential margin, which is
exactly.
hugely important in
Yeah,
this disease.
yeah,
And if you take, just like with pancreas, you take a more than 1 millimeter margin on histopathology as being the clearance, your actual
Yeah, R0 rates will,
R0 resection will plummet.
there are about 4 or 5 margins you need to
Yeah,
concentrate on.
yeah.
Liver is usually clean.
Hmm.
Distal resection is usually clean.
Usually clean. It's
So
a
it leaves the bile duct
yeah,
and the circumferential or radial margin, and
yeah,
radial margin is often the culprit.
yeah.
But Sanjay, do you do histology of the margin when you
So
are resecting?
So I always take the biopsy in drop because I find that when the specimen is sent to the pathologist, they totally muck up the
Margin.
whole thing gets contracted. It's
Yeah, yeah,
impossible to make out what
yeah,
is what.
yeah.
So I prefer to take the biopsies, take a thing at the time of the resection. But I don't bother with the frozen section, I must say, most of the time, because I know that I've done the maximum, and
Yes.
there has been data to show that yes, you may be able to, in some patients, get a negative margin if you take further. But one, it increases the risk of bile leaks and complications post-op, and it also does not alter survival. Meaning, the margin has no meaning if you have got nodal disease.
Yeah.
So nodal disease trumps the biliary margin for sure. There are many patients who have insight to this biliary intraepithelial neoplasia 1, 2, 3, or in situ carcinoma. It makes no difference to their survival in the vast majority. So what you're looking for is actual invasive carcinoma, or you're looking for the submucous tumor.
We shouldn't forget that if there is an intervention, it makes it more complex
Much more difficult for them
to
to
evaluate the margin.
absolutely.
And as you mentioned, there's this interesting article, I think a couple of years back from Mayo Clinic, which talked about 150 cases, which talked about margin negative, margin positive, and then second margin negative,
Yeah,
margin positive, and second margin also positive.
positive.
The latter two did not have any difference in outcome.
Yeah,
From, as you said, that if you strive to get a margin after a positive margin, it
yeah.
increases the risk, and apparently it doesn't improve survival.
It doesn't seem
The
to.
recurrence rates are same in margin positive always, or margin negative in the second attempt.
Yeah,
And nodal disease, as you said, is more in
yeah,
margin positive, negative, this thing.
yeah,
So, I totally conform with what you're saying, that you do the best the first time. And then if it is positive, that's your bad luck or the patient's bad
yeah.
luck. Would you do a R1 resection knowingly? So you're there, you've done most of the resection, and you feel that this margin, but you can't go any further. So would you do that?
I would. Once I've done if I'm in the surgery and I've divided parenchyma and I'm at the level of the thing and I've gone, I would just finish it.
So then this brings us to the next part, which is vascular, because as we said that vascular involvement is critical. So we know if it is ipsilateral, it can be removed, portal vein. Now we have enough evidence that resection, and it's easy to reconstruct after a major hepatic resection. The key remains the arterial resection and reconstruction.
Yeah.
So, what's your thought now, after all these years, that where does that stand?
So I think number one, it is a technically possible thing. I think nowadays, especially with LDLT expertise and all that, uh, it is something which can be done.
Yes.
How much of a benefit it has is more of a problem. In that, when we look at our series of, it's a small series, but with our arterial resections, but most of these patients survive 2.5 years, which they may have
No
survived
complications.
without. Arterial infiltration meant greater degree of, I mean, I think about 90% of them plus had documented perineural infiltration. uh, huge number proportion. I think about 70% of them or 80% of them had nodal disease. So you're looking at a much more aggressive tumor generally.
Obviously, we are talking of a situation where you're doing a left hepatectomy,
Absolutely.
right artery is involved.
Yes.
Either come back
No, I
or
think they
do a resection of the artery.
abandon if you don't have the
Yes,
ability.
yes, yes.
But if you have the technical expertise and the experience and the support services to permit arterial resection and reconstruction, then I think you should do it. And the way to do it is to find I mean, I look in the Ruvius sulcus, and you'll usually be able to find the right posterior artery right in front there and follow it back and see whether you have got a
Good.
artery which can be reconstructed. But we have had a few patients who have had long-term survival. I'm talking about 4 or 5 years with an arterial restriction, but it's a minority.
I want to ask you, Sanjay. One is
Just
reconstruction. The
dissection.
Leeds group, they've read about no reconstruction or
Yeah.
even arterioportal anastomosis.
I think no reconstruction to me makes sense. We do this operation whenever we're doing an arterial reconstruction, we do the operation entirely from the left side. So there is no mobilization of the remnant liver at all. The caudate resection, the left lobe resection, everything is done from the left side. We don't mobilize it off the diaphragm at all. So
Right.
it allows for any collateral
Yeah.
uh, to form. And we have had out of I think maybe 16 patients we've done this on. We've had two patients who we could not reconstruct after we thought we would be able to. We got a lousy reconstruction and abandoned it.
Hmm.
Fortunately, the patient was fine and
Okay.
got collaterals. And the second patient, we had to put an interposition graft, and 3 or 4 months afterwards, the artery had thrombosed. I have more of a problem with the arterioportal anastomosis because it causes severe portal hypertension. And
Hmm.
if you've got a borderline remnant,
Permanent.
you're going to run into serious problems. But I prefer to try to reconstruct, just
I'm
not.
just thinking that if you do a left resection and don't reconstruct the artery, even if the liver survives, biliary complications would be high in that.
Doesn't happen. It doesn't happen. They don't seem to get this to the extent that you would imagine
Hmm.
that they should. I think it's partly not mobilizing. It's partly that you've got a hepaticojejunostomy on healthy ducts without scar tissue in there.
The next important issue which comes, you resect, and you have two scenarios, a R0 resection and a R1 resection. I want to bring in the role of adjuvant therapy. I mean, is it just something which you do because you don't have any options, or does it really work in hilar cholangiocarcinoma? What is your experience, and how often and in what scenarios do you use adjuvant therapy?
Okay, adjuvant, I pretty much give it to everyone. Like if it's a very elderly person who has got no nodal disease, no margins in the final thing because you have also come back negative, then I might not consider it. This, I think the literature shows positive results, but not dramatic results. I don't give radiotherapy,
Yeah, that
but I
was the
give
next thing that if it is R1, would you add radiotherapy?
I
I mean, I agree that literature is not very,
yeah.
robust as far as radiation is concerned.
Yeah.
You
So
know,
it's one of those situations where I would individualize, but I prefer not to, frankly. I prefer to just give the chemotherapy because I have used radiation sometimes and ended up with nasty
I
strictures.
mean, what I have seen is that we primarily are relying on bill cap to tell us that adjuvant has.
Yeah.
It's very interesting when you look at other studies
Yeah. There's
that
not.
it's, the overall survival in bill cap with adjuvant is lesser than the studies which have shown no benefit
I
with
know.
adjuvant, and they are almost double, as a matter of fact, 65
Yeah.
months to 35 months. And bill cap, of course, has a
But
combination,
it's
or
yeah,
it's a
that's the whole
mix of,
problem with all these studies.
yeah,
They put all of these biliary tumors together.
together.
So
Yeah.
because but it
To
doesn't
sift
really.
out. You
Yeah,
use it for
yeah,
gallbladder also, you use it for this.
yeah.
You don't know actually
Which one is
where
the
it works or it works
best?
at all. Yeah, and I think the same would be about neoadjuvant. Would you use
I
neoadjuvant?
have not used, and I reviewed this a little while ago. It's somewhat difficult to decide which patients to give neoadjuvant to. There is one center in Japan which has published a few where they've called this borderline resectable.
Use S1, I think. Yeah,
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 and they have said if there's vascular involvement or nodal involvement, or you think that you have close margins on biliary margins
yes,
on resection, then that is borderline
yeah,
resectable, and you give chemo. But the problem is that nobody has shown really benefits in
yeah,
resection, and on the contrary, there have been patients who were operable who became inoperable. Now, there's this eternal argument,
yeah,
okay, does that mean bad tumor biology? Yes, it
yeah,
does. But,
yeah,
at the present time, I think there may be a role in these arterial involvement situations. There may be, I think that for
yeah.
venous involvement and lymph node at the moment, I would not give, because I don't even know what the endpoints are in this. Are you going to make the node sterile? I don't know. You probably won't.
But you
So
know that the lymph node is a bad prognostic
you
factor.
know that it's a bad
Everything.
prognostic
So
indicator
might as
anyway.
well try. I mean, I would like look at it. I want to just address one more issue, and that is about parenchyma preserving
Yeah.
surgery in hilar cholangio. What kind of parenchyma preserving, and how do you choose which patients to, or who are suitable for this?
The parenchyma preserving means that you're essentially resecting segment 4 and segment 1. So you're doing
Yeah,
like a central resection.
central kind of thing.
Resection, and the segment 4 you don't have to resect the entire segment 4, but the base of segment 4B is what
OB.
you're
Yeah.
resecting.
I mean, so in other words, will the gallbladder cancer type of resection work in hilar cholangio? 4B5, that
with
kind of
one with one with
with one, of
with
course.
one, yeah.
Yeah.
So it can, and then that depends again on what the extent of the tumor is. So if you have a tumor which is uh, not extending, say on the right side, you have a decent margin to your secondary confluence on the right side, and on the left side it's maybe at most extending up to the segment 4 insertion, and again you've got a decent margin beyond that. Then you can consider, I think we underuse these resections, to be
Yeah.
frank. We
Yeah.
should
I
look
think
at it more
yeah.
critically, and I think it's vital in older patients, but it is an underutilized thing, and I think there is a role for looking at more closely.
Like, say, for example, there is often a dilemma in type 1 kind of hilar cholangio that which side of
Yeah,
liver to
yeah,
move. And perhaps for those ones, this
yeah,
may be an ideal
yeah.
surgery.
Type
And,
one, type two,
yeah, yeah,
both be,
ideal
would be
thing with preservation.
absolute.
I mean, Sanjay, we've gone through this whole thing and we find that there are several challenges. What inspired you to get into this complex area? I mean, it's a thankless job.
But Sadik, you and I and so many of our colleagues are the same. We love a challenge. We agonize through the challenges when they don't work out, but we love to face the face the challenge, and I think that's just a personality type. I also love the fact that you're working with multiple disciplines. That's what I like about transplant as well, that you're working with others, and it's not just surgical expertise which is improving, but other things which are also improving at the same time, and you're making little bits stepwise progress
Yeah,
in these patients. And I also like the fact that many a time patients, I would say at least half the patients, as not so much now, but earlier that I used to see, had already been told they were unresectable and there was nothing to be done for them. And
quite often happens
quite
now.
often happens, so these were the challenges that got me hooked. And then as often happens as an individual patient, I was also in this thing of draining everybody, and I would have terrible challenges with cholangitis and all the usual things. And then I had this lady who came and said that, look, I don't have any money. I don't have the money to do this, that, and the other. She was young. She
Mm,
had a bilirubin which was over 20. She needed a left resection. She was fit. Uh, and we had a long discussion with her, and we just went ahead and resected. And to my surprise,
mm.
he didn't have any post-op liver failure with a bilirubin over 20.
Yeah.
Then, I got
Yeah.
into
There's
this thing
always
of
that
maybe that you
watershed
can,
time
yeah,
that
that,
you,
there's something that
yeah.
maybe you can make a difference by trying to change the management, that kind of thing.
If suppose I was to be starting my career and I listened to you and I say, oh, I want to do Hilar cholangiocarcinoma. What would be your advice in terms of that, okay, you do some liver dissections and all, and so you can go ahead and start doing, or you need to get insights, work with someone, watch someone, and then get into it. How would you, shepherd a person in
I
this?
think these kind of things you always benefit from working with somebody, preferably in a high volume center, not necessarily doing the operation, but being involved in the planning and
Planning.
the thought process behind each patient. And I would also say that you shouldn't do it too early in your career because sometimes you don't know what you don't know. And when you go and see somebody else doing it, it looks so easy because it's routine for them, and then you try to replicate that at home and make a mess of it. So find out what your own strengths and weaknesses are, get a certain level of expertise in doing standard liver resections, dealing with the problems of perioperative problems of liver surgery, and then maybe spend a period in a good high volume center, whether it's in India or abroad.
Better to get the insights into it and how the actual planning goes, and
That's
I understand that. Great, Sanjay. Thank you very much for spending your day or afternoon with us.
Thank you for having me. It's been a real pleasure. And, as you said, we've known each other for so many years, and it's always been a pleasure to interact with you and deal with you. And I'm a great admirer of yours, as you know.
Thank you, Sanjay. Finally, was able to get Sanjay to sing a few notes for us.
Got me in the water, me to the river. Dip me in the water, see me down, washing me. I don't know why you treat me so bad. Think all the things that we could have had. Love is an ocean that I can't forget. My sweet 16, I would never regret. I want to know, can you tell me? I'd love to stay. Take me to the river, drop me in the water, push me.
Thank you, Sanjay. Thank you very much.